All right, everybody. Welcome back. Okay. So today we will hopefully be wrapping up with our study of the reproductive system. So we're going to try to finish out this section on the female reproductive system. And then on Wednesday, I'll bring some study and review activities for your exam for Friday. Okay, but let's get going. All right. So when we left off, we had been talking about the menstrual cycle. We'd gone through changes that we see within the female reproductive system over the course of the month, and also mentioned some of the changes we expect to see over the lifespan. So next, we're going to be talking about the process of fertilization and what happens if we actually do fertilize one of these egg cells. So we're going to be thinking about some of the processes related to pregnancy and birth. Okay, so I wanted to do just a quick reminder of some stuff that I'm hoping you've covered in a lab. So just positioning us relative to our female reproductive anatomy. All right, so we've been talking about what's happening in the ovary and the ovarian cycle. So that's our gonad that we're thinking about. And then we have our uterine tube or our fallopian tube. I don't think these subterms were on your list in lab, but I'm just going to point them out to you right now in case I mention them. So we have kind of these little finger processes at the end of the fallopian tube called fimbriae. Then we have a swollen kind of area called the infundibulum. Leads into a kind of horn-like section called the ampulla. Okay. And then when we get to the uterus, on the top of it is the fundus. Then we have the body. And then the bottom third or so is the cervix. Okay. And that's going to lead us into the vaginal canal itself. Okay. So we're going to lead into the vagina from here. All right. And we'd have another fallopian tube on the other side, another ovary on the other side. So what we were talking about when we were talking about ovulation, we were talking about how we have an egg cell coming out of a mature follicle. We know that this kind of bursts out of the ovary, and then it has to enter the fallopian tubes here. Okay, so positionally, that's where we are. Okay. So picking up with your slides. I was mentioning that to you because a kind of surprising or potentially surprising thing about fertilization, implantation, and pregnancy is that when we see fertilization occur, it's not actually happening like in the uterus. That's usually happening in the uterine tube, often quite near the ovary. So often we're in this infundibulum ampulla kind of area when fertilization takes place. Now, that's partially because of essentially the lifespan of the relevant gametes. Okay. So the way it works is this: sperm are going to be viable. They can survive for up to like 5 days, but our oocyte, our egg cell, is only viable for 12 to 24 hours. So like a day or less. Okay. So if that ovum is not fertilized within those 12 to 24 hours, pregnancy is not going to occur. And that oocyte is being ovulated into those most distal parts, those farthest out parts of the uterine tube. Right? So we've got this situation where the oocyte is kind of slowly making its way towards the uterus. It's usually not there yet when it encounters sperm, because sperm are moving, they're swimming through the reproductive tract, they're going up through the vagina, through the cervix, through the parts of the uterus, and then they start heading up the uterine tube towards the ovary itself. Okay. So in order for the sperm to do this swimming through their 5-day lifespan, we do have to have one kind of final piece of maturation happen. And this actually happens in the female reproductive tract itself. So sperm are deposited in the female reproductive tract. they're going to undergo this process of capacitation. So it'll be on the next slide as well, but capacitation basically enables the sperm to start swimming quickly enough to actually move through the reproductive tract and changes their membranes a bit so that when they finally get to that oocyte, when they finally get to that egg cell, they can fuse with it. So that's going to require some changes. Okay. So the sperm are swimming up, they're swimming up into the uterine tube, and the oocyte is coming down to meet them. So from ovulation, we have that antrum bursting, spitting out our oocyte with a little bit of extra tissue still around it. Okay. And so that fluid movement is going to have the oocyte getting caught by those fimbriae, those kind of fingery processes at the end of the uterine tube. That's going to be pulling it in, pulling it towards the uterus. Okay. So in the uterine tube itself, we'd expect to see peristaltic contractions. So peristalsis, just like progressive squeezing, like we saw in the GI tract, like we saw in the male reproductive system when we were thinking about ejaculation. Okay, so the oocyte is going to be moving towards the uterus through peristalsis for a little bit after that initial fluid movement, but that doesn't get you all the way to the uterus either. So after those initial peristaltic contractions, we're going to take advantage of some cilia that we have in the uterine tube. So cilia, again, are like tiny microscopic fingers on apical cell membranes. So those are going to keep moving the oocyte towards the uterus. Okay. And that process takes a few days. The whole trip takes about 4 days, right? So if we're thinking about that diagram I just drew you, we have our ovary, we have our uterine tube leading into our uterus, right? We are not getting to the end of that before that oocyte loses its viability, right? So we've had ovulation occur. We get a little bit of the way, but we only have 12 to 24 hours to get there, right? So let's say a day. But to get all the way to the uterus, that would be like 4 days. Okay. So this is also why we see that fertilization usually happening somewhere here, right? Because that's about where that egg cell gets to by the time its period of viability ends. That doesn't usually get much farther than that before it kind of degenerates, dies off a little bit. Okay. So the sperm have to meet the ovum, have to meet this egg cell during the 4 days that they're traveling towards the uterus, usually early on in that time period because of this difference in viability. Okay. So the sperm are heading up towards this egg cell. They are trying to be the one that wins out, that fuses with our egg cell. Okay. So they're entering the female reproductive tract through the vagina. They're undergoing capacitation that's going to make it possible for them to fertilize an oocyte when they find one. So that's increasing how fast their tails move. That's changing their plasma membrane so that it can combine well with an ovum. And they're swimming, swimming, swimming up through the reproductive tract. So through the cervix, through the body of the uterus, heading into the uterine tubes. So initially during ejaculation, there are like millions of sperm that are getting deposited, but throughout this trip, as they're traveling, we're going to see less and less sperm making it to that point. So their overall survival time in the reproductive tract is approximately 5 days, but that's not going to be for each and every one of them. They're not all great swimmers, for one thing. It's usually only about 100 of those million sperm that make it into the uterine tubes. So here's another picture. This is a figure from your book, but I want to show you again what we're thinking about when we're thinking about these different locations. Okay. All right, so we got ovulation occurring here. Here we have our egg cell, our oocyte, our ovum here entering the uterine tube. And here we can see that we're tracking what happens if our egg cell is fertilized. So here you can see it meeting up with the sperm pretty near to that ovary, okay? So these are the 100 lucky sperm that made it into the uterine tube. Whichever one gets to the ovum first and actually combines with it, because it's undergone capacitation and can fuse with that oocyte. Once that happens, this is going to be sending out signals that basically prevent other sperm that might be in the area that might have made it this far from also fusing. So we're going to start suppressing everything else around us if we have this fertilization event occur. That's because when we think about like numbers of chromosomes that lead to viable embryos, a viable fetus, if you have essentially 3 parents, because you've got multiple sperm and an egg cell, that's not going to lead to viable fetus. That's going to be the wrong number of chromosomes. So that's why you got to suppress the other ones. Okay. So here we see what's happening to that ovum, to that egg, and then to our fertilized egg over the course of its journey to the uterus. So if you have fertilization occur here, right, we're going to have that fertilized ovum. We're now going to refer to it as a zygote, right? So our zygote is our ovum that's fused with our winning sperm cell. And you can see that it keeps all its kind of cellular material here. So when we think about where did the mitochondria for a growing fetus come from, that's going to be coming from this ovum. This is why when we track mitochondrial DNA, you're tracking a maternal line, right? So egg cell bigger, forming most of the cellular machinery in this zygote. And then we see a series of steps where we have many cycles of division. So we started out with just the 1 egg cell and the 1 sperm cell forming this fertilized zygote. And then we're going to do cleavage as we start to see these early changes, these early cycles of division, early mitosis happening. There are lots of names that refer to exactly what stage we're at, so exactly how many cells there are, but we're going to go from a 4-cell stage early on in cleavage. You can see we're still not down to the uterus yet. You can see a morula is a lot of cells, right? So we've done several cycles of division. Here we're about 3 or 4 days after fertilization. We are still not down to the uterus yet. We form a blastocyst when we start to see some shapes kind of forming that are different than just this sort of general collection of multiple cells. So you can see here we're starting to make regions within our little clump of cells here. So we have an inner cell mass. And we have this kind of hollow section. We have an outer section when we're looking at this blastocyst, still not implanted, but now we're entering the uterus. And so this is about the stage at which we would see implantation happening. So an implantation is going to be happening about 6 days, so about a week after fertilization. We're going to see that growing fertilized egg that's now starting to get shape. We've made this blastocyst and this blastocele. We're going to see that implant into the uterine wall here and start to kind of anchor itself. So we can see here what the uterus looks like at this initial kind of implantation point. And here you can see it kind of spreading into the uterine wall, anchoring itself in there. We can see that we have a rearrangement of some of the blood vessels in the uterine wall, getting ready to kind of feed this growing embryo here. Okay. So when we think about this process, one way to kind of test ourselves to make sure that we understand what all these events are. And also something that's going to be relevant to your potential patients is by thinking about birth control, because we can kind of target any or many of these different events that have to happen in order to prevent pregnancy. And different methods are going to do different things. So we're going to run through some of those different types of birth control so that you're well informed when you go out into the world, go out potentially talking to patients about their options. Yeah. But from an anatomy perspective, from a physiology perspective, we've got methods that are going to stop sperm from reaching the oocyte, reaching that egg cell in the first place. So that's one way we can do it. We can prevent pregnancy by stopping the ovaries from ovulating. So if our ovaries never release an egg, then there's no egg in the fallopian tube to be fertilized. So that's another way to prevent pregnancy. We can mess with the properties of sperm, right? So sperm have to undergo capacitation in order to be able to swim all the way to the all the way up the uterine tube, almost to the ovary, and then they have to be able to fuse with that egg cell, which means that if they can't do that, if we change qualities of the sperm, they may not be able to get to that egg cell, and they may not be able to fertilize it even if they do. We have specific ways of changing the female reproductive tract that also kind of block sperm. One in particular is the cervical mucus. So we talked a little bit about cervical mucus when we were talking about the different uterine phases within the menstrual cycle, right? We mentioned that we have changes to cervical mucus when we move from our proliferative phase to the secretory phase. So we can use birth control to change that cervical mucus, to thicken it, to make it difficult or impossible for the sperm to move through. And then we can also change properties of the uterus to prevent implantation. Realistically, a lot of fertilized eggs are passing through people's systems kind of naturally. I guess I won't say a lot because we don't really know, but it's relatively normal for an egg to potentially be fertilized, but to have implantation not occur, to have implantation not succeed. And in that case, you would never know it happened because you would just pass that fertilized egg cell the same way you have a normal menstrual period. But we can do that on purpose by changing the uterine lining as well. Okay. So there are different types and classes of birth control that may be of interest. So the most dramatic, most permanent, most successful is going to be actual sterilization. So when we talk about sterilization, really the most common forms that you're going to see are going to involve basically damaging the reproductive tract, kind of cutting it off. So either sperm don't exit, or so egg cells don't actually have a way to meet up with that sperm. So in male anatomy, if we're thinking about a vasectomy, sorry, this is covering our label here, that's going to mean the vas in that is the vas deferens. So if we create a gap or a seal or a plug in that vas deferens, then we are not going to be able to have sperm leaving our testis, going through our epididymis, up the vas deferens into the spermatocord. If we cauterize this, cut it, put a gap here, those sperm are not going to continue into the body, into the ejaculatory duct, and then out through the urethra. And on the female side, we can get to those fallopian tubes. So they do kind of narrow as they are entering the uterus in a region called the isthmus. So we can do a tubal ligation, which is going to be the same kind of thing. We're going to cut or block that tube there, right? And so that works kind of on both ends. If sperm are coming up and they reach the gap, they can't continue. And on the opposite side, if our egg cell, we ovulated out, it's starting to come down towards the uterus, it would also get blocked here with the tubal ligation. Next up, we have some barrier methods. So for barrier methods, we're thinking about literally putting a barrier between the sperm coming through and the potential egg cell coming down. So we have condoms, both female and male condoms, that do that, basically catch the sperm. We have a variety of ways we can block the entrance to the cervix. So a diaphragm or a sponge or a cervical cap all close over that entrance to the cervix, and therefore any sperm deposited in the vagina can't make it through the uterus and into the uterine tube. And these are usually combined with spermicides and contraceptive gels that also kind of start to kill off the sperm along the way. Finally, we have a bunch of different hormonal methods that vary in how long they're active. So we have some daily methods. So birth control pills or morning after pills, Plan B, those are going to be regularly changing your hormones. You're going to need to maintain that. We also have some longer acting hormonal methods like hormonal IUDs or the Depo-Provera shot or the implant that was in a longer term kind of change the hormonal cycling in females and therefore prevent pregnancy that way. So we're going to walk through that since we now know a little bit about how hormones work during a typical menstrual cycle. Okay. So we're going to think first about birth control pills because that's a particularly common method of preventing pregnancy, as well as treating a number of different conditions, actually. So from the birth control side of the birth control pill, that's going to be preventing ovulation usually, and maybe a little bit preventing fertilization, depending exactly what we're talking about. But there are many other benefits to the birth control pill, and it can be used to treat a number of different conditions and to treat people with specific risk factors. One cool thing is that ovarian cancer, if you already have cancer, it's not going to be treated by a birth control pill, but if you're at high risk for cancer, you may be prescribed a birth control pill because we see a 30 to 50% decrease in the risk of ovarian cancer when combined with long-term birth control pill use. There's also a significant decrease in the risk of endometrial cancer, so the endometrium being that kind of lining of the uterus. Because of the changes that we see to hormonal cycling with the birth control pill, this can also help with cramping, can help with PMS or premenstrual syndrome, can help with anemia because there's blood loss happening during a menstrual cycle, and the birth control pill can limit that. It can relieve symptoms of endometriosis and prevent some ovarian cysts. It can treat acne, it can treat excessive hair growth, and it can help with polycystic ovarian syndrome as well. Okay. So it can do all these things largely through changing hormonal levels and kind of stabilizing them. Depending on the exact pill, there are going to be different formulations. So we're going to be talking just kind of in general here. The most common formulations, though, combine both estrogen and progestin, which is basically a synthetic version of progesterone. Okay. So the role of estrogen in the birth control is largely to suppress our LH surge. So we know that the LH surge is happening right before ovulation occurs. We saw that change in how estrogen is working related to the hypothalamus and the anterior pituitary that allowed for that LH surge. Estrogen in a birth control pill is going to keep that LH surge suppressed. So it's going to work like that figure we saw for the early and mid follicular phase, keeping us from seeing a spike in LH. So a reminder what that looked like. All right, so we had follicular phase, our LH levels were low. They were partially being kept down by negative feedback, partially from estrogen. Then we saw a spike right before ovulation, causing ovulation. And then we saw that sinking down. And we had seen that estrogen levels varied a little bit throughout the ovarian cycle, basically having kind of two swells, follicular and then luteal. Okay. So if we can suppress that LH surge, we're suppressing that anterior pituitary from releasing that luteinizing hormone. So ovulation doesn't occur. If ovulation doesn't occur, there is no egg cell in the uterine tube to be fertilized, which is why that's an important part of the formulation of birth control pills. Oh, I had pulled this figure in again. Okay, so here we see estrogen, and here we can see that we have that suppressing action of estrogen throughout most of the follicular phase. And it's as that estrogen starts to go down that we see the LH surge. So if we stabilize these estrogen levels, keep them high by giving someone estrogen, we're going to see consistently high levels of estrogen because we're taking a pill, we're taking a supplement basically for estrogen. And that means that suppressing action is going to carry through the whole month. So no ovulation. The other thing, this is usually a combined pill with progestin, which is that synthetic form of progesterone. What this usually does is it prevents fertilization by blocking sperm. And the way we're blocking sperm is by thickening the cervical mucus. So remember that progesterone is something that we usually see during the luteal phase because it's coming from the corpus luteum. And that's lining up with that secretory phase in the uterus. We're already seeing some changes to cervical mucus. We mentioned that if fertilization and pregnancy occur, that cervical mucus gets so thick that it actually forms a plug in the cervix to prevent pathogens from coming in and damaging a growing embryo or fetus, right? So this progestin is essentially speeding that process up. So it's essentially tricking the body into acting like it's pregnant a little bit, blocking that entrance to the female reproductive tract by blocking entrance to the cervix. So we've got two things that's going on here with this combined pill. We're not ovulating, so there shouldn't be an egg cell in the first place to be fertilized. And we're also blocking sperm coming into the reproductive tract at all. So we've got kind of a double action here, bringing the possibility of fertilization way down. Now, there are risks as well to hormonal birth control. There's risks to pretty much everything you can do medically. And I am highlighting these for you in part because I don't know how well advertised some of these risks are. I had a friend who had a stroke at about 27 because her doctor didn't mention these risks. So I'm telling you now. So one particular risk is that if you are at risk for stroke and blood clots, this might not be the best choice for you, might not be the best choice for a patient like that, because we do see that in patients who have these elevated risks, oral contraceptives can kind of increase the likelihood that a clot will form and get stuck somewhere, get stuck in your brain. That's how a stroke happens. Yeah. We also have a variety of ways that oral contraceptives or birth control pills can fail. Many of these have to do with not like fully ingesting or metabolizing the contraceptive. So vomiting and diarrhea for a long period of time. We're praying 48 hours, so like 2 days here, right? If you're vomiting up, then your birth control pill doesn't have enough time to actually make its way into the bloodstream. On the other side, right, if you have diarrhea, we're moving through the GI tract too quickly for that absorption to happen as well. There are also other medications that interact with oral contraceptives in ways that can tend to deactivate them. So some antibiotics, as well as some antifungals, some anti-seizure meds, and even some supplements like St. John's wort kind of deactivate oral contraceptives. So that would be something to ask patients about as well. And the other thing, if we're thinking about patients, you always want to be treating the person who's actually in front of you. With a lot of medications, we got to think about dosage then. So one thing that is coming out in the research is that these haven't always been dosed entirely appropriately. So sometimes obesity plays a role here as well. Some of our current formulations of oral contraceptives don't work that well if you're working with a patient who's significantly overweight. So you might want to look into the specific formulation that you're considering prescribing. Okay. Hi, everybody. All right. So a related birth control method is emergency contraception. This is basically going to work the same way that these hormonal birth controls will. So we're thinking like Plan B here. It goes by many names though. Okay. So emergency contraceptive pills are something you may see patients using if we have an accidental failure of a birth control method, or in cases where a patient was not thinking that intercourse would happen and it did anyway. Right. So these are going to be taken after a copulation event or an event that might cause fertilization, and we're going to be trying to stop pregnancy kind of after the fact. But they basically only work if ovulation hasn't happened yet, right? So they have a limited kind of window of efficacy, in part because they're primarily working the same way that our hormonal birth control does. They're primarily preventing ovulation, right? So we need that fertilizable, that viable egg cell to be there for fertilization to occur. It's only there for 12 to 48 hours. If you are before ovulation, you can use hormonal birth control to prevent ovulation. If you are after that 24 hours past ovulation, there's not going to be an egg there to be fertilized in the first place. So that's the kind of logic behind why a patient might use Plan B or hormonal or this emergency contraceptive here. Okay. But that does also mean that if your patient is unlucky and has just ovulated, this pill isn't going to do anything. Okay. So we're preventing ovulation, and that covers most of our bases in, by covering these events where fertilization should occur. Sorry. Okay. So moving on to a sort of different type of hormonal birth control, but we've got at least one non-hormonal method here as well. We can think about long-acting reversible contraceptives, or LARCs. So long-acting, we're saying we want things that work for months, work for years. Your patient doesn't have to do anything. Reversible, meaning we're not thinking about sterilization. We're thinking about something that you can remove and have your patient come back to a period of fertility. These are currently the recommended kind of first line contraceptive by the American College of Obstetricians and Gynecologists, because they're really effective and your patients don't have to be perfect in order to use them correctly. So when I say they don't have to be perfect, a lot of the other contraceptive methods involve sometimes unrealistic standards, because you have to take a pill at the same exact time every day. You have to put on a condom well before there are any sperm anywhere near the female reproductive tract. And that's not always what actually happens in people's lives. So here we're looking at the failure rates for some of our long-acting reversible contraceptives, which are going to be the IUDs and the implant. So here we can see that the difference between typical use and perfect use of those methods is like there's basically no difference, right? So they work the same because there's not really anything you have to do. But if we look at the rates of failure for either the combined pill or a progestin-only pill when we're looking at the percentage of women who have an unintended pregnancy in the first year that they're using it, right? With typical use, like what we actually see people doing, you're going to see about 9% of women experiencing an unintended pregnancy, whether that's not taking the pill at the right time every day, whether that's thinking it's going to cover you when you're taking antibiotics, things like that. Versus the perfect use, our theoretical efficacy of that combined pill would be in line with these long-acting contraceptives here. So if we're thinking about effectiveness, I'm going to walk you through what's least effective to what's most effective. Patients may be choosing any one of these methods, whatever people want to do in their lives, valid. Okay. However, when we look at the least effective methods, that's going to be mainly our barrier methods, as well as fertility awareness-based methods. So you can see that failure rates here are between like 18 to 24% for these different methods. So they help, but especially without perfect use, especially without really understanding what's going on, not as effective as especially some of these long-acting contraceptives. I want to make a note about these fertility awareness-based methods because I didn't mention them when I was talking about those different classes. What those are using understanding of what physical changes you expect to see throughout a menstrual cycle to determine when did ovulation happen, and then just kind of planning intercourse to avoid that period when you would expect to see a fertilized egg cell moving through, or sorry, a viable egg cell moving through the reproductive tract. However, we do see a pretty high error rate there because while we have nice kind of textbook ideas of when should ovulation be happening, day 14, what should you see happening around that time, specific changes in cervical mucus as we're moving from our proliferative phase to our secretory phase in the uterine cycle. Bodies are weird. They do weird stuff. Ovulation can happen way too early in the month. It can happen way too late in the month. Sometimes hormonal signals are changing in response to all sorts of environmental factors, so it can be a little unpredictable. And your body may not be creating those changes as fast in cervical mucus or some of these other observable traits as you might hope if you're using this method. We look forward to our more effective and then our most effective forms are various kind of hormonal methods, as well as a couple of our barrier methods are pretty effective, but our most effective methods end up with less than 1 pregnancy per 100 women in a year, pretty good rate. And those ones are going to be either sterilization. This does say sterilization is permanent. That's not exactly true. In particular, vasectomies are reversible, although there's always a question mark there, but they're pretty easy. But sterilization, definitely going to drop risk of pregnancy. IUDs and implants are also particularly effective. Okay. So I'm going to talk a little bit about IUDs because they're becoming more popular, especially because of that recommendation from the College of Obstetricians and Gynecologists. So this is what most doctors use on themselves. Okay. But we got 2 types. So we've got a hormonal IUD that's going to be basically slow releasing little bits of hormone, particularly progestin, over the course of the month. This is going to have the same effects that progestin does in a combined birth control pill. So this is going to change the cervical mucus in order to kind of plug up the cervix and block sperm from traveling through. Has some handy side effects. So we see a reduction in cramps because we see these changes to hormones. So your body is not really getting the same signals as it usually would. This withdrawal from progesterone is usually what causes a period. So with a little bit of this supplement there, that can ease cramping and other period issues. And the hormonal IUD, this is a little bit of an old graphic. It says this is effective for 3 to 5 years. I think it's up to 7 to 10 with some of the new hormonal IUDs. There's also a non-hormonal IUD made of copper. So this isn't releasing any hormones at all. What it's doing is using the effects that copper has on the environment in the uterus to decrease the rates of pregnancy here. That one, unfortunately, can cause increased period flow and increase cramps. Okay. So thinking about those long-acting reversible contraceptives, I don't have a figure for you about the implant, but there's an implant. You put it in your arm, works for several months. This prevents ovulation through those kind of hormonal methods that we've discussed, but you don't have to remember what time to take it every day. The copper IUD, non-hormonal here. This is basically producing kind of an inflammatory response in the uterus. And as the sperm move into the uterus and try to get to the uterine tube, they die off at way, way higher rates even than they usually do because of this inflammatory response. We've created a really inhospitable environment for sperm. And we said that of the million that are released during ejaculation, only about 100 were making it to the uterine tube in the first place. All right, so this usually gets them. Finally, the hormonal IUDs. The progestin is usually the main thing that's working here. So for the most part, the way that we understand them to work is that they're really, really thickening that cervical mucus, and they're thickening it so much that it physically blocks sperm from entering the female reproductive tract. There are some other potential additional effects that occur with hormonal IUDs. Again, they're different hormonal IUDs, but that's the main thing. That's the thing that we think in the literature is really causing this reduction in pregnancies. So note about those IUDs, you'll see a variety of sources out there, and some of them have in there that IUDs are preventing implantation as their method of action. And our current research says that that's not really what's happening, that maybe in a couple incidental cases that could have happened, but overall, it's really this thickening of cervical mucus. And part of the reason we don't think that that's a major way that they're working is that if you place an IUD in someone who is already pregnant, already has an implanted fertilized egg, these hormonal IUDs do nothing. They don't disrupt pregnancies that have already implanted. And while extremely rare, you'll notice none of those numbers in the efficacy rates were 0 pregnancies. There have even been some successful pregnancies that happen with IUDs still in place. Okay, so nothing's foolproof. Yep. So our last little topic here is we're going to be thinking again about estrogen and progesterone, but now we're going to be thinking about what they're doing during pregnancy. Okay. So a reminder, when we're thinking about estrogen and progesterone, we're chiefly thinking about the ovaries and what is happening during the ovarian cycle. Estrogen is largely coming from our follicles within the ovaries. So we see that start to ramp up as our follicles are getting bigger. We see a drop in estrogen right before ovulation, which is part of what allows this LH surge, in addition to a kind of positive feedback effect of the estrogen that is remaining. So we see a drop after ovulation because the mature follicle has released its egg, but we see another ramp up in estrogen during the luteal phase because the corpus luteum is a gland and it takes over some of that hormonal action. For our progesterone, it's way down kind of near 0 during our follicular phase of the ovarian cycle because the follicles don't make progesterone. It's the corpus luteum that makes progesterone. So we see that progesterone come up as we enter the luteal phase after ovulation. And we see progesterone go down in the latter parts of the luteal phase because that corpus luteum is only really big and doing its job for about 10 days. Then it decides you're not pregnant and starts to die off. Okay, so we see lowered levels of progesterone in later parts of the luteal phase, and the withdrawal of that hormone is the signal to your body that fertilization and implantation have not occurred. So that's what triggers a menstrual period, triggers bleeding, triggers shedding of the uterine lining, which is what loops us back to the beginning. The beginning of these cycles is the first day of a menstrual period, is the first day that someone would observe this bleeding, shedding of the uterine lining. So if we're thinking about what these hormones do during pregnancy, we'd be thinking about a really different graph. Right? So looking over here on the right-hand side, you can see what's happening with estrogen in red here, right? So instead of having these kind of rises and falls on a monthly basis, we see estrogen going up and up and up until right before birth. Here's parturition. That's our word for birth. Okay. Progesterone, we see the same thing happening. We see progesterone going up and up and up. And we can see that dropping down again right at the time of birth as well. We can see we're tracking another hormone on here in addition to estrogen and progesterone. So we're tracking a hormone called human chorionic gonadotropin, which is usually abbreviated HCG. Okay, so this is something that we only expect to see in pregnant women, right? So you can see it's at 0 until we get to kind of the end of this first month. Okay, I do want you to note the x-axis of this graph does not say pregnancy specifically. It says months since start of last menstrual period. Okay. So an important thing to realize when you're counting days or weeks or months that someone's been pregnant, we are not counting from fertilization, which theoretically should be happening around ovulation. So around day 14 of the menstrual cycle. So about 2 weeks in to the menstrual cycle. We count from when the last menstrual period started. So technically, when fertilization happens, on average, the moment fertilization happens, you are already 2 weeks pregnant because we're counting from the date of the last menstrual period. So on average, kind of any woman is potentially a week pregnant already, which is kind of fun, kind of crazy, not necessarily expected. Okay, so looking at the time, we'll touch in a tiny bit on these hormonal changes on Wednesday. When we start, we have really just 2 slides left, and then we'll do some review activities.